I'm a community oncologist, and there's been a major change in the CLL treatment landscape recently from traditional chemotherapy with its usual toxicities now more to the targeted agents, and that change in treatment is still continuing to evolve. We generally try and tailor the treatment towards the patient's disease characteristics and the patient characteristics. So it depends on the age, fitness status, comorbidities of the patient, and as well the characteristics of their CLL, main things now being whether they are 17p deleted or have heavy chain mutations. Ibrutinib is a fairly big part of treatment nowadays in CLL. Of course, in the relapsed disease, it's by far and away the commonest agent that's used. It's also gaining some traction for first-line treatment, especially in the older, less fit patients, patients who have a unmutated heavy chain, or if they're 17p or p53 positive. So this was a trial of using Ibrutinib as a lead-in and then combination therapy of Ibrutinib with Venetoclax for a fixed duration of time. Essential to the trial, they did MRD testing, and although they haven't reported it yet, they'll be looking at stopping treatment and then seeing how patients do off treatment or on a chemotherapy holiday, whatever term you like. We have very early data. I guess the one thing that's fairly well established is that the Ibrutinib lead-in really downgraded the risk of tumor lysis syndrome. And once the Ibrutinib lead-in was done, I think there was only one laboratory case of TLS seen in the whole group, and I think they said almost nobody needed to be hospitalized to prophylax against TLS. So that's a real success, I would say. I think the most important efficacy data was some of the MRD data, right? They were showing that after a few months of the combination therapy, there was 80-90% rates of MRD in both the bone marrow and the peripheral blood. There seemed to be very little discrepancy between the two, which I thought was an interesting point as well. And they also said that the 17p deletion patients did just as well as the ones who did not have 17p. Yeah, as far as safety signals, to me, the striking thing was that there weren't any, right? It was basically the expected toxicities, and the only thing that seemed perhaps a bit more than either agent was there was a little bit more neutropenia when you combined the two agents, but overall the toxicity profile seemed very manageable and comparable to the single agents. I think treatment holidays are very important for all patients, not just CLL patients. My general belief is that the patients have better quality of life when they're not on treatment. I mean, the phrase I use is institutional fatigue, right? We keep them on treatment, they keep coming back, and continue to pay parking and rack up all these other medical costs that they continue to complain of, whereas patients love it when you give them a treatment break. Of course, the key issue there is you don't want to compromise their outcome, and hopefully studies like this will allow us to do that, although the data is still pending. It's too early, I think, to say it's going to impact, although it fits one of the trends, which is giving new agents in combination for a defined period of time. And the other thing we didn't talk about is they're measuring MRD in this, which in a community hospital, we're getting set up to do all of this. Right now they do it at some, not all of the academic centers even, but I think the main reason is once we get data that doing all of this is effective, we'll simply have to do it in the administration and so on. We'll have to put up the money. So right now, I think this is more a glimpse of the future than an actual change in practice.